All right, the presentation today is about disability status and disability issues. And let me give you an overview of what we're going to review. So first, a little bit about what is a disability and definitions. We'll also talk about the history of disability, especially in the U.S., models of disability, so different ways to understand what disability is, and then how to interact with it. And then toward the end, we'll talk about principles to consider when working with folks with disabilities. So first, with regard to ability and disability, um, an important question to ask is who defines disability? Is this something that someone defines for themselves? Is this something that others define for them? So, for example, if I see someone and they have an illness, am I the one who says that they have a disability? Do I categorize them in that way? Or does the government, or is it a self-identification? Also, this brings up questions about the social consequences of a disability. So, how are folks with disabilities treated? And this also connects with issues of health and illness. Many people who have disabilities have conditions that, like health conditions or illnesses that cause the disability. But again, what is health and what is illness might also be a social construction. So then for the purposes of this class, we'll say that a person has a disability when there is a physical or mental condition that limits the ability to perform a major life activity, such as walking, breathing, seeing, hearing, thinking, or working. And with the ADA, they include also the statement of a person may be considered to have a disability if they're perceived to have that disability by other people. Because if someone perceives you as having a disability, they might discriminate against you. So even if you don't maybe qualify in some ways or you don't self-identify as having a disability, there are laws that would still protect you if others might view you as having a disability. And this connects with our larger conversation about oppression and privilege because there's a system of discrimination that excludes people with disabilities, and we call this ableism. So this exists on individual, institutional, and cultural levels, and it provides advantages for people who are temporarily able-bodied, and it disadvantages those who have disabilities. Now, I'm a person who I am currently able-bodied. I do not have a disability, and so today I'm speaking about this from a knowledge perspective and sharing what I think are important things to know, but I'm not sharing about this from a personal experience perspective. All right, so moving on, the Americans with Disabilities Act is the most comprehensive civil rights legislation in the U.S. for people with disabilities. And this protects rights such as employment and participation in government and social activities. And this is important because it allows people with disabilities to fully participate, and it recognizes that people with disabilities face prejudice and discrimination. Disability is stigmatized in our culture. And so the Americans with Disabilities Act is a public and governmental recognition of that fact. All right, so next going into what the Americans with Disabilities Act of 1990 is. So first I'll say that it was signed into legislation on July 26, 1990 by President George H.W. Bush. And as I said before, it's a comprehensive piece of civil rights legislation. It guarantees that people with disabilities have the same opportunities as everyone else to participate in mainstream American life. Protects their ability to enjoy employment opportunities, purchase goods and services, and participate in state and local governments. It also is similar to other civil rights legislation that prohibits discrimination based on other things such as race, religion, national origin, those kinds of things. And the ADA does not name specific impairments, or it doesn't name all specific impairments. It focuses actually on functional ability. And so let's talk about that specifically now. All right, so the definition of the Americans with Disabilities Act It defines disability as being with someone who experiences a physical or mental condition that limits the ability to perform a major life activity, such as walking, breathing, seeing, hearing, thinking, or working. The second prong of the ADA definition, it goes further in defining those who might be discriminated against on the basis of disability by saying that people who have a record or a history of disability are also protected from discrimination. And then the third prong protects people who have no disability at all, but who are perceived to have a disability. So the second and third prongs of the ADA were established to recognize that disability discrimination is a phenomenon unto itself, that it exists even when someone may not have an actual physical disability, okay, or mental. All right, so let's see. Other important things to think about with regard to the ADA is that it's a public recognition that physical and mental disabilities in no way diminish a person's right to fully participate. Yet, many people with physical or mental disabilities have been precluded from participating because of discrimination. And others who have a record of disability or are regarded as having a disability have also been subject to discrimination. And historically, society has tended to isolate and segregate individuals with disabilities. And even when there are social improvements, such forms of discrimination continue to be a serious problem. Even with the ADA now, there's a serious problem of exclusion and folks with disabilities not having access to public services and programs. So let's see. The ADA also says that discrimination against people with disabilities persists in areas such as employment, housing, public accommodations, education, transportation, communication, recreation, institutionalization, healthcare services, voting, and access to public services. And unlike individuals who have experienced discrimination on the basis of race or other things, individuals who have experienced discrimination on the basis of disability before the ADA had no legal recourse to address the discrimination. So this has meant that they have been excluded, discriminated against, not been able to use transportation or enter public buildings. There have been communication barriers. There have been overprotective rules, such as treating folks with disabilities as weak or incapable. Segregation, relegating folks with disabilities to lesser services or programs or activities. They may not have benefits, jobs, and other opportunities that more able-bodied folks have. And there's census data, national polls, lots of studies that document that people with disabilities as a group have an inferior status in our society, and they're severely disadvantaged. And there's also research to suggest that the nation's goals about this should be full participation and independent living for folks with disabilities, because as we discriminate against folks with disabilities and give them unequal status, then first of all, we say that we have a free society, but then that is not exactly the case. And then it costs the U.S. a lot of money and unnecessary expenses because we put folks with disabilities in dependent positions and don't give them the equal access so that they might be productive members of society. Okay, so the purpose of the ADA is to provide a national mandate to eliminate discrimination against people with disabilities. So it's a national mandate. It also has clear, enforceable standards to address discrimination against people with disabilities. So again, it's a mandate, and there are these standards that have to be upheld. And then the federal government, within the ADA, the federal government plays a central role in enforcing those standards, okay? And this means that congressional authority, federal government can enforce those standards, and so the power of the federal government can come behind folks with disability to make sure that they don't face discrimination and have recourse if they do experience it. So on the screen, I've given you some types of disabilities and examples of them. So there might be mobility disabilities, There might be psychiatric. These we might be more familiar with, including depression, bipolar, schizophrenia, PTSD, and others. So you can qualify for a disability because of psychiatric condition. Also, auditory disabilities such as being deaf or hearing impaired, developmental, speech, environmental, and medical. And within the medical, this is where the health and illness stuff comes into. Okay, so with all that said, let's talk briefly about models of disability. And why this is important is because disability is a social construct. So different people, different societies will perceive disability in different ways and give it different meaning. Now, there are three predominant social constructions or social models of disability that we're going to talk about. First, the moral, then the medical, then the minority model. And each one of these defines what the problem is, who holds the problem, and then best avenues to address the problem. Because what you do depends on how you define the problem and who you think holds it. All right, so the first one is the moral model. This is the first and the oldest model of disability. And within this model, disability is seen as being caused by a moral lapse or sins. And a theme that you might, if you hear this theme within someone's understanding of their disability, you might think that they're operating from a moral model, and the theme is shame. So a disability might cause someone to feel shame about themselves, or maybe within their family or social group, depending on how collectivistic that culture is. Some things that you might hear from folks who are working from a moral model of disability is they might see their disability as maybe a test by God, or maybe a sentiment that if they'd done something differently, then they wouldn't be experiencing the disability, or they wouldn't be suffering as much. There might be a sense that something is wrong with them. For parents of children with disabilities, there might be a sense that the disability is a result of their bad actions, and they feel guilty or ashamed of what they did or didn't do. This can exist within religious and spiritual people. You might think of the idea of karma, that a disability status, comes upon a person because of something they or other people did previously in other lives, or family history. But this can also exist in folks who are not religious or spiritual, and one way to pick up on it is the theme of shame. So next, moving to a more medical model. Within this model, the person still, just like in the moral model, the person still holds the problem, and the disability is seen as being directly caused by a disease or trauma or other health-related condition. So then management of the condition is aimed at a cure or adjustment, and the body is central in that. So medical care becomes the main issue, and any kind of political strength or funding would go into research on medical issues, technology, for example, for assistive devices, trying to reform healthcare so that folks get the medical care that they need. So within this model, you're still trying to move the person with the disability from whatever functional impairment they have up to more typical levels of functioning. And now, next we'll move into the minority model. This is a social model of disability. And this is the model that we're going to use most in class as a social way of understanding disability. And the idea is that disability it's recognizing that disability is a social construction. And so the problem doesn't lie with the person with the disability, but mostly it lies with the negative views or the stigmas that are held by society. And the problem is that the environment isn't accommodating the person with a disability. That this is kind of flipping the other two models on their heads, because in the other ones, the problem lies with the person, and so therefore you try and help the person or cure the person. Whereas in this one, the problem is with society, so then instead of trying to bring the person to the level of society, you're trying to bring society to adapt to the person. All right? So then also within this model, persons with disabilities are seen as a minority group because they have differential power, they have a group awareness, a cohesion potentially within the group, experiencing themselves as different from the majority. There's an experience of discrimination, higher rates of institutionalization, and lots of social barriers, and there are pervasive negative attitudes about disability, and this is a major obstacle in rehabilitation or equal access. So the idea here is that the collective action of society at large is needed. It's needed. The society needs to make environmental modifications so that people with disabilities can have full participation in all areas of social life. And the issue is cultural, ideological, and access is seen as a human rights issue. So here I've listed out some additional issues. When you think of a minority group that a minority group might experience, and so folks with disabilities might experience also, this includes a pressure to assimilate or become more like typical able-bodied folks, concerns around intermarriage, hate crimes and abuse, lack of standardized testing for folks with disabilities, pressure to be a model minority and succeed, fewer public role models. Those that are in public might not be figures of excellence, often blamed or held responsible for things. Disability tends to include pain, fatigue, and weakness that are kind of just consequences of the disability and the stigma attached to it. Folks with disabilities are underrepresented in many professions, including clinical psychology. They're underserved generally in mental health. They go without services and suffer for that. They tend to be politically underrepresented. They also face insurance risks, and this can also be have a financial cost to it. They're at a higher risk for school dropouts, substance abuse, and unemployment. And again, this is not just because of the disability. This is because of the social stigma that is related to the disability and the pain and suffering that that causes. There's also unacceptability of certain emotions. And then a prescription of others. So we might expect grief and not expect, I don't know, joy or sexual satisfaction. So yes, certain emotions are prescribed and others are unacceptable. And disability is also expensive and time-consuming because our society is not set up to accommodate to or meet the needs of folks with disabilities. All right, so let's turn now to issues, principles to consider in treatment. And I'll begin this by saying that it's important to expand your framework for therapy. When you have this minority model and see things as, see the whole system and the social construction of it, you might need to interface with the medical world, maybe even legal or political systems. You also might need to flex your own understanding of, I guess we'll get into this in a minute, but of the frame of therapy. Also, biculturalism is very important because people with disabilities are essentially bicultural. They go back and forth between the disabled community and non-disabled larger world. And so it's important for you to have a sense of what the disability community is, what the values are there, so that you can understand what it's like for them to straddle both of those communities and some of the stresses that might be related to that. Next, having a systemic model. This is important because disability is a family affair. Disability affects the person with the disability, of course. It also affects the family. It may affect partners. Also, it will affect you and your treatment. And so even if you're doing individual therapy with someone with a disability, it's important to keep the whole system in mind. There may also be a need for additional skills. In general, you're going to learn clinical wisdom and skills throughout your years of training and education, but it's important to understand the typical presenting problems of folks with disabilities so that you can modify your diagnosis or do case formulation a little bit differently to integrate the disability. Most of the time when working with a person with a disability, we kind of might go one way or another, focusing too much on the disability. And that every problem is related to the disability, which is not the case, or not talk about it at all, like it's an elephant in the room and you're just focusing on the depression and not thinking at all about how the disability may be related to it. So when you're thinking about assessment, diagnosis, case formulation, treatment, termination, you might need to have additional skills or consult about that. Then beyond deficit reduction, the idea here is that often in therapy we think about decreasing negative symptoms like depression or anxiety. It's also important to think about optimizing functioning, like health or psychological well-being. And so with folks with disabilities, make sure that you focus on the latter one, optimizing functioning. This can counteract negative messages and prejudice that they've experienced throughout their lives. And then the need to show and not just tell. So professionals like clinical psychologists will need to demonstrate their expertise about disability. The person coming to see you has no reason to assume that you have any kind of expertise. They have no reason to assume that you're not prejudiced or that you won't discriminate against them in some ways. They've probably experienced a lot of that throughout their lives. So it's important to be prepared to demonstrate that you can work from a minority model, that you can be open to learning, and that you also have expertise. And this is all in the attempt to make therapy a smoother, more beneficial process for the patient and you. Some of you may have a lot of experience working with disability because of experience in your family or your own life. And that is great. You are likely to be prepared to demonstrate your abilities. And for those of you that have less experience, it's a good idea maybe to learn, train, and consult. Okay, so a few more general principles to consider. Of course, be flexible. This means that all kinds of things might change. So you might need to be open to more feedback from the client. You might need to shed old stereotypes and prejudices and be very aware of them so that they don't affect the therapy. You might need to change the parameters of therapy, such as being flexible at frequency of sessions or the time of day of sessions, the length of sessions, that kind of thing. Also be open and empathic. This might seem obvious. I think it's mostly what we're trained to do, but one of the traps of working with folks with disabilities, that might be the wrong way to say it, but watch out for your compassion, because sometimes when we are too readily compassionate, it can kind of be similar to treating folks with disabilities like they're weak or pitiful or needy, and that is a stereotype and a message that they may get often. So watch your compassion and don't try and help unless the person really needs help. You may have to utilize your time and resources out of session. This may not be something that you're used to doing, but working with organizations and reading material outside of session. Also, understanding and managing your own countertransference. This is important because we all have stereotypes, and it's important to be aware of those and be aware of the strong emotions that might come up with you when you're working with a person with disability. And the idea is to be aware of it and utilize it in the therapy. Also, asking about disability. Yes, it's important to ask about it, so don't be afraid to ask. You are a therapist and not a random stranger on the street, so as you're working to understand the person you're sitting with more fully, you can ask questions about it, such as, like, what is the nature of your disability? Try and stay away from things like what happened to you or what's wrong with you. Another question to ask is, are there ways in which your disability is a part of your presenting problem? And that is a way that you can understand how those two are linked, and maybe they're not linked much at all, or maybe they're very directly linked. A few other things. So the relativity of time is important to consider. Many things do take longer if you have a disability. Every disability is different, but tasks that may take extra time include things like getting ready for session, taking time to talk, excuse me, that might just take more time to get words out, writing a check or getting situated in the office, walking down the hallway. So be aware of that, and you might need to develop your own rhythm of what you do while the other person is taking a little bit longer. So be patient. Making treatment accessible is very important. Try to be aware of how your treatment or your office setting all kinds of things about the therapy may duplicate or perpetuate the client's difficulties that they experience in everyday life. And see if you can adapt yourself or make your therapy more accessible to the folks you're sitting with. So by this, I mean physical access, right? So thinking about stairs, elevators, width of doorways, the kinds of chairs in your office and who will be suitable and who they won't be. Is there room for a chair, for example, like a wheelchair? But not just getting to and inside of your office, even things like timing and pacing, like handing a receipt to someone as they walk out. Maybe they don't have grip strength and are not able to hold it. But so think these things through. And of course, you might make mistakes, but try and be aware as possible about how accessible your treatment is. Okay, a couple other things that I want to say before we wrap up the clinical implications is that the idea of empowerment and how important it is to empower the person that you're sitting with when you're working with someone who's disabled. Empowerment is a big issue within the disability community, and I think that therapy can be a way to really empower folks. A couple other rules about etiquette. This may be obvious, but don't stare. Sometimes it's hard to do because some oddities come with disabilities or things that you're not familiar with. And so if that draws your attention, that's okay, but try not to stare. Don't tell folks with disabilities about the other people you know with disabilities. Don't assume that they need your help. If someone comes to your office with an assistant, who helps translate things or accompanies them for other health-related reasons, be clear about who the client is and talk to the client. It's very disempowering to have someone speak about you to another person. And the last thing that I'll say is don't worry too much about the language that you use. So, for example, you might say things like, do you see what I mean, to someone with a visual impairment, or it's nice to see you today. You might tell your client that you'll walk out to the waiting room with them and they're unable to walk. Those kinds of phrases are probably to be expected, but also just try and be aware of how those things affect the person that you're sitting with. It may not be a big deal at all, or it may bring up strong emotions for them. And as you think about accommodating the person you're sitting with in every way, the words that you use, the temperature of your office, the frequency and duration of sessions, those are all things that you can do to accommodate your environment to the person that you're sitting with. All right, that's where we're going to end it for today. For more information, I would encourage you to read What Psychotherapists Should Know About Disability by Rhoda Olkin. Also, the ADA is online, and it's very, very interesting. If you have any questions about what the Americans with Disabilities Act is, you can find a lot of great information there. All right, thanks very much, and I'll see you in class.